All right, hey everyone. If you've ever been on a GI or surgery rotation, you know this patient. They come in with pancreatitis, and then weeks later, a CT scan shows a new fluid collection. It can be pretty confusing. So today, we're going to break it all down and build a really simple, powerful framework so you know exactly what you're looking at and, more importantly, what to do about it.
And this is it, right? This is the exact question that pops up on rounds. It feels like there's a ton of confusing terms out there, but I promise, by the end of this, you are going to have a crystal clear path from looking at that scan to making the right call for your patient.
So here's our game plan. First, we got to start with the pancreatitis itself. Then we'll follow the timeline. What happens in the first 4 weeks, and then how those collections change after 4 weeks. And finally, we'll get into the real practical stuff, diagnosis and management. It's a logical flow that totally mirrors what you'll see happening with your patient.
Okay, let's get into it. Before you even think about the fluid, you have to know what kind of fire you were dealing with in the first place. Everything, and I mean everything, that happens next depends on what type of pancreatitis your patient had right at the beginning.
So acute pancreatitis really splits down two main paths. On one hand, you've got interstitial edematous pancreatitis. Just think of this as the pancreas getting really swollen and angry, but the tissue itself is still alive. On a CT scan with contrast, the whole gland just lights up nice and uniformly. But on the other hand, you've got the much more serious necrotizing pancreatitis. The name says it all. Parts of the pancreas have actually died. And the dead giveaway on a CT is that those areas don't enhance. They don't light up with contrast, which tells you that tissue is necrotic.
And I can't stress this enough. That distinction is the single most important one you're going to make. It is the fork in the road. Why? Because a pancreas that's just swollen and inflamed is going to produce a very different kind of fluid than a pancreas that has dead tissue breaking down inside it. This is the key that unlocks the whole system.
And here it is. This is the cheat sheet. This simple 2x2 grid is the revised Atlanta classification, and it makes everything so much clearer. Look, the rows are just the two types of pancreatitis we talked about, interstitial or necrotizing, and the columns are just a timeline, less than 4 weeks and more than 4 weeks. Each box gives you the exact name for the collection. It's really that elegant.
Okay, so let's zoom in on that first column. We're in the immediate aftermath now, less than 4 weeks since that first hit of pancreatitis. What do we see?
So if your patient started with that less severe interstitial pancreatitis, any fluid that pops up early on is called an acute peripancreatic fluid collection, or an APFC. The key words to remember here are homogeneous, meaning it's just clean fluid, no solid stuff in there, and lacks a wall. It's basically just a puddle of inflammatory liquid that hasn't been organized yet.
But if the patient had necrotizing pancreatitis, that early collection is a totally different beast. It's an acute necrotic collection, or ANC. The big difference? It's heterogeneous. It's not just fluid, it's got chunks of dead necrotic gunk floating in it. And just like an APFC, at this early stage, it doesn't have a wall around it yet. Now let's fast forward. What happens after about a month? Well, the body is an amazing thing. The inflammatory response kicks in and starts to build a wall, trying to contain these messes. And this is where two new, mature players enter the game.
So that APFC, that simple, clean fluid, can mature into a pseudocyst. What's that? Well, it's still just homogeneous fluid inside. The big change is that now it's encapsulated. It's got a nice, well-defined inflammatory wall around it. We call it a pseudocyst because it's not a true cyst with a special cell lining, it's just a wall made of scar tissue.
Now, this one's my favorite, because the name tells you the entire story. The acute necrotic collection matures into walled-off necrosis, a WON. Walled off tells you it's now got that mature, enhancing capsule, and necrosis tells you what's inside, that nasty mix of fluid and solid dead tissue. It's all right there in the name.
Okay, so we've got the 4 names down, but how do you actually tell them apart when you're staring at a CT scan in the reading room? Well, you just have to look for a few specific clues.
So when you pull up that contrast-enhanced CT, here's your mental checklist. First, look at the contents. Is it perfectly black, just homogeneous fluid? That points you toward an APFC or a pseudocyst. Or is it kind of murky and gray with heterogeneous debris? That screams ANC or WN. Next, look for a wall. Is there a bright white enhancing ring around it? If yes, you know you're past 4 weeks dealing with a pseudocyst or a WN. If no wall, you're in that early phase. And always, always glance back at the pancreas itself. If you see parts of it that are dark and non-enhancing, that confirms the original problem was necrotizing pancreatitis.
So we've named it, we've identified it. Now for the million-dollar question, what are we going to do about it? And this is where management has really changed over the years.
This right here, this is the single most important rule. You have to burn this into your brain. We treat the patient, not the scan. Just because you see a huge collection doesn't mean you automatically have to stick a needle in it. In fact, most of these, especially epiphyses and a lot of pseudocysts, will just go away on their own if you give them time. So when do we jump in? The answer is actually pretty simple. You intervene for symptoms or for infection. That's it. So your thought process is a simple two-step. First, is this collection causing a problem? Is it so big it's squishing the stomach and making the patient vomit or blocking the bile duct? Second, is it infected? Does the patient have a fever, a high white count, or do you see little gas bubbles in the collection on the CT? If the answer to both of those questions is no, then the best management is usually just watchful waiting.
So you see, every one of these fluid collections is really just a chapter in a story that started with that initial pancreatitis. You just have to ask, was the pancreas just inflamed or was there necrosis? Did it have time to build a wall yet? If you can answer those simple questions, you'll know its name, you'll understand its nature, and you'll know exactly how to take care of your patient. So next time you see one, what story is that scan telling you?